You wouldn't buy a car without a seatbelt, a laptop without Wi-Fi, or go a day without your cell phone. Could a business survive without the internet? Then why are many healthcare providers and provider organizations still not connected and enabled to share critical clinical information digitally in the care of your friends and family? Welcome to Kno2fy, a podcast from Kno2. Join host Dr. Peter Schoch, Chief Health Officer, and Therasa Bell, Founder, President, and CTO, as they bring the profound impact of healthcare communication to life through frank conversation in understandable language and through real-world context. They'll demystify interoperability, helping you unlock the potential of healthcare communication at scale. You'll also learn the transformative impact of being Kno2 connected. Connect, listen, transform.
Welcome back, everybody, to another episode of Kno2fy, and I can't tell you how excited I am to have a special guest with us today. Today on our show, Therasa, we've got the head of the ONC. Is what we just went over this, and I can't even remember what the title is. But I call him the head of the ONC. Dr. Mickey Tripathi is here with us today. We have had a big milestone at Kno2 that we talked about in our last episode of the podcast in becoming designated as a QHIN. We've had Mickey in some joint presentations in the past, but so pleased to have you here, Mickey, today. I'd love to just take a minute and have you introduce yourself and talk a little bit about your role at the ONC, and then we'll kind of get started. I know, Therasa, we've got some things we want to talk about and plug here upcoming in the next week or so. So, Dr. Tripathi, I'm going to turn it over to you and have you introduce yourself, if you don't mind, sir.
Okay, great. Thanks. Really delighted to be here. So thanks, Peter and Therasa, for the opportunity. So we were just going over this, as Peter mentioned. I think my title actually is National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services.
Mickey, I think I might just informally stay with head of the ONC.
Years, I think I've got it down. So, yeah, we are a staff division in the Department of Health and Human Services, report directly to Secretary Becerra, and our role is kind of twofold. I think of it as like a vertical and horizontal. The vertical is working with the market. Great companies like Kno2 and others who are out in the market trying to advance adoption of interoperability based on open industry standards. And then the second, and doing everything we can to support adoption of health IT in the best interest of patients. And then the horizontal is I think more and more important, at least in the time that I've been here. I've tried to make it more and more important, which is working with our federal agency partners to get alignment in their use and their support of everything we're trying to do from a mission perspective, which is an open architecture health IT ecosystem based on open industry standards that best supports patients.
I love that. And when you say other federal partners, you're talking about things like Department of Defense, CMS, those types of agencies.
So we have a broad array of agencies that are just under the HHS umbrella, like CMS, FDA, NIH, HRSA, CDC. I mean, it's an amazing number of agencies just under HHS. And then, of course, like VA, DOD, Social Security Administration, and others.
That's wonderful. Mickey, I'm so looking forward to the conversation today. We're going to talk a little bit about the history of TEFCA QHIN, how it kind of rose from the ashes of the 21st Century Cures Act as that got dusted off. And we'll talk a little bit about that roadmap. But I also want to get into some of the things about, okay, it's here now. What does it mean for healthcare? What could it mean for healthcare? What kind of things are keys to the success of TEFCA QHIN and moving interoperability forward, making Therasa's lifelong dreams come true around interoperability? And then what are potential barriers that we need to address and be aware of? And what are some thoughts around how we overcome those? And then I also want to touch on what you were just talking about, and that is, how are the rest of the agencies and sister agencies at the federal government viewing TEFCA QHIN, and how does their participation potentially drive additional market adoption, et cetera? So, Therasa, that's a lot to talk about today. I hope we can get it all done. I'm going to have to be quiet, aren't I, today?
I don't know if you can do it. We're going to be here a while, Mickey. I hope you get to like 3 hours.
Right. Now, I don't know if it's possible.
I
was going to say, I don't know if it's possible, but Peter, you may have to speak faster too.
I I think you're an auctioneer on the side, right? That's what you do on the
Well, I do a little bit of that. I got to make money everywhere I can.
Right.
No question.
I'll say I
Yeah,
talk fast, but you put me to do
you two do. I think you give each other a run for the money. I will say that I'm very excited about this episode. Obviously, it is. I don't know if it's a lifelong dream. I don't recall having this when I was, in my, 5 to 15. But absolutely, in my career, I've been very focused to seeing interoperability take place, and because I believe it is the only hope to make sure our healthcare system is kind of redirected, and we start to save costs, we start to change the provider experience, and those needs have only accelerated, and especially post COVID. So, and personally, I'd mentioned this before, but I've tracked to Mickey. He probably kind of awkward even saying that. He probably thinks he has some sort of stalker, but I've tracked to Mickey. That
Let's stay away from
You're
certain
the one.
keywords like stalker.
It is.
Yeah, I feel like Mickey is purely motivated to solve these problems, and I personally enjoy this honor to be able to watch all of this come to fruition, watch his hard work come to fruition, and our participation in that. So I'm very excited for the conversation today.
And Teresa, I know we got a couple things we want to plug coming up here, but first, Mickey, I'm going to ask you a personal question. What does a guy who has led the charge to bring TEFCA QHIN to actual life? What do you do to de-stress? I see a guitar in the background there. What is your Zen place? What do you do to de-stress and relax?
Yeah, the guitar is actually more of a source of stress because it's a reminder that I'm not playing.
I've got the same one behind me.
Actually remove it. It's like, either do it or move it. I thought move it closer and then I'll just pick it up. No, but I do. I live very close to to family. My mother and my wife obviously and kids, and have 2 grandchildren. So spend a lot of time doing that. Spend a lot of time running, and I run pretty often because I have a dog who needs to go out, and if we don't somehow channel that energy, she will destroy the house instead. And I play squash. That's the other thing.
Nice. Yeah, nice. Teresa's a big runner as well, and the exercise certainly turns off the bad parts of your brain and turns on the good parts of your brain. No question about it. Well, Teresa, we got a couple things upcoming in the next several weeks. I know Vive is a big destination for a lot of people who may be listening to the podcast. And I know we're going to be there, and I believe Dr. Tripathi is going to be there as well. You want to say just a minute about just a little bit about Vive and in our presence there, Teresa, and then Mickey, happy to have you as well.
Yeah, I'll say for Vive in general, I think this year Vive is really exciting because of the number of designated QHINs that we have, and there's so much attention around it that it will create. We've had the right conversation for a long time. I actually look forward to the first national show, whether it's Vive, HIMSS, or Health, where we don't talk about interoperability, because I think that means that we've done our job, and that it's actually happening at scale. The reason we continue to talk about it is it's not realized yet, right? So I'm excited for this conversation, excited for Vive, because we've hit a major milestone, and in particular, obviously for Kno2fy, this is a massive milestone in the audience that we carry forward as it relates to the unique audiences that we serve in the overlooked markets, to have them realize it. So very excited for Vive, very excited to have Dr. Tripathi there and push forward.
So, and Teresa, just to be more logistically precise, we'll have a booth there in the Interop Now Pavilion. We'd love to have you stop by and say hello if you're there. We will be giving 2 different presentations, a presentation around interoperability, solving healthcare's biggest problems in the Interop Now Showcase, and then you'll be talking about our journey to becoming a QHIN and what you think that means and what it means for Kno2fy, et cetera. And then we've got, I'll just plug the Interop Now podcast. If you are a listener of this show, please listen to that show. We have a couple of episodes. One will be releasing right before Vive, and then the other one will be coming out after Vive as well, where we talk a little bit more about some of the issues around interoperability and the promise of realized interoperability as you talk about. Mickey, I know you're going to be at Vive too. You're traveling as much or more than I think Teresa and I are to these different things to get the word out. What's got you most excited about Vive, and where can they find you?
Yeah, I'm definitely traveling a lot, and more than I would ever want to in my personal life. But I feel like it's just such a critical part of the job. It's really easy I was in the private sector for 20 years before taking this job 3 years ago, and I noticed within a month how quickly isolated you can become just being a federal employee, just because of sort of the nature of the job and the nature of the work, and all of the ways in which you sort of have to work. And so I just think it's such a vital part of the job to actually be out as much as possible, keeping on top of what's going, and most important, listening. And so that's so Vive is obviously a huge opportunity to be able to do that with so many people gathering. I think it's sort of a great venue for that. I'm going to be participating in a number of on Sunday. I think there's a bunch of payer provider meetings, which are really important as I know we're going to talk about TEFCA. One of the important things that that we have put forward is that we need to be able to get payer provider interoperability to be a core part of our nationwide interoperability infrastructure and approach. And we're also going to be talking about, of course, AI. So I'm going to be doing a joint session. I think it's one of the plenary sessions with my really good friend Troy Tasbez from the FDA. And we're going to be talking about AI regulations, how we're jointly thinking about AI strategy at the department, ONC and FDA working together, and have a few other meetings, with the fire accelerators. They usually come together at the Vive meeting to talk about, like, this is like the Argonaut Project, Da Vinci, Vulcan, the wide variety of fire accelerators that are out there now, to talk about how we can help sort of motivate all the great work that we're doing that turns into things that are actually implementable.
That's wonderful. I was on the prep call for Vive, and I think one of your teammates was on there, and she asked, "Can I make sure that we get all the information about his various different speaking venues?" So you're going to be busy at Vive, and I would encourage anybody who hasn't had an opportunity to hear Mickey talk live about some of these important issues. It would be a real benefit to you. Mickey, you have a real easy way of explaining some very complex issues that I think make it very real for people, and I think people can really benefit from that. So we're going to take a quick break, and we're going to come back, and we're going to get right into the heart of it. So we'll be right back.
Uncover the narratives that fuel Kno2's success on the Employee Spotlight segment of the Kno2fy podcast, where we delve into the unique stories and passions propelling our team forward.
My name's Ellie Whitwell. I am the accounting and HR manager. So I pretty much do what my title says. I manage all accounting procedures and HR procedures.
Perfect. What do you believe your why is for working at Kno2 or in healthcare technology in general?
Well, my why for working at Kno2 is because I've seen what a difference it makes. I have known Therasa Bell for many years, and she brought me along with her on this journey 10 years ago. And it's been pretty life-changing to see the difference it's made in healthcare.
I love that. Yeah, we're making some big changes out here in the industry.
Yeah.
Do you have any funny nicknames or nicknames in general?
Funny you should ask. I have one nickname that Therasa gave me. She calls me this all the time, Smelly.
Why?
I think just because it rhymes with Ellie. I hope that's the only reason.
I like it.
So we'll be in the office sometimes and I'll hear Smelly. And I try to clarify to those that don't know me.
That's why, I swear.
Yeah.
Okay. Can you name one thing you hate and one thing you love?
Well, let's see. I hate arrogance, and I love my family.
Good answers. I love that. What show or movie are you embarrassed to admit that you love?
Oh, embarrassed to admit that I love. I don't know. Not much embarrasses me. Well, recently, I don't love this, but Married at First Sight kind of got me hooked. That one's kind of embarrassing.
That's a good show. That's a good show. What can I say? All right. What's the first thing that comes to your mind when I say think of a happy memory?
Being in Maui on the beach with
Ooh.
my family. Those are good memories.
That sounds like a great memory. That sounds
Yeah.
awesome. What outfit or trend or hairstyle, etc., do you wear or have had growing up that you would look at now and say, oh my gosh, why did I do that? Like something you'd be mortified to look at yourself wearing now, or a hairstyle you have now.
A hairstyle would be when I was 9 years old and I had a bi-level haircut.
All
So
right.
it was like cut short. It was like I had bangs and then it was cut short at my ears, for anyone that doesn't know what that is.
Yeah.
And then long, kind of like a mullet.
Yeah, absolutely. No, I was a hairstylist for like 8 years before this, so I absolutely get you. I've seen some funky trends go in and out.
Yeah.
So what would you say your favorite book is?
My favorite book, I like fiction, and I read for pleasure pretty much. So I like a book called The Forgotten Garden by Kate Morton.
That sounds great.
Yeah, it's a World War II. It goes, in and out of history, modern times, and it's good.
Would you rather visit the beach or the mountains?
Oh, the beach. Yeah.
Well, thank you so much for taking time to meet with me. It was great chatting with you.
Stay connected for more captivating insights into the exceptional individuals driving innovation at Kno2. Connect, listen, transform. This is Kno2fy with your hosts, Dr. Peter Schoch and Therasa Bell.
Welcome back, everybody, to Kno2fy. Today we're talking with Dr. Mickey Tripathi, and so pleased to have him here. We're going to talk about a lot of stuff today and hopefully cover a lot of information around TEFCA and QHIN, the road to get here. But I think we're also going to get into what we all are really ready to talk about now, which is the impact and how do we realize the impact. So let's get the conversation started, Therasa.
Yeah, I think it would be great for the audience, for those that haven't tracked to it, or there's a lot to track to, but maybe let's go backwards to go forwards for a second, if you don't mind, Dr. Tripathi, and take us through the history of TEFCA, QHIN, kind of how we got here today, if you don't mind, and then we can jump right into it, Dr. Schoch. I think that might be good for the listeners.
Yeah, that's perfect.
Participating.
Sure, happy to. So this is Mickey Tripathi's rendition of the history of network interoperability. I guess in some ways, one of the things, I mean, I'm always looking for, kind of overall context. Like to me, it's just sort of, because we tend to, maybe that's partly because I'm old, and so I've worked in a number of different industries. I still consider myself pretty new to healthcare because I've only worked in healthcare for 20 years. But prior to that, I worked in the Defense Department for a number of years as a federal employee, and then worked for a strategy consulting firm and worked in a number of different verticals, consumer goods, financial services, did a lot of work with the pharma industry for pharma clients, including working in Europe and in India with clients there as well. So someone had the benefit of being able to see, other industries up close. And so, in many ways, I think we tend to think of things like TEFCA and the things that we're going through as being unique to healthcare, like, oh, healthcare's so broken compared to other industries. And I think in the context of, sort of looking at the trajectory of, like, especially, industries where, technology adoptions happen rapidly, information technology is a key part of, of the industry, that we're following a pattern that's very similar to other sectors. In some ways, we're sort of lagging in a way, but, I think that there are certain reasons for that that are unique to healthcare. And the reason I say that is that as we, sort of build up to TEFCA, I would argue that it is really just another point on the maturity of an industry that is adopting health information technology and adopting network types of services and network business and technical approaches to be able to get greater efficiency and greater value. And if you look at financial services, if you look at airlines, if you look at the travel industry, if you look at retail markets, I mean, every single one of them went through a similar kind of trajectory. And I think one of the things that makes healthcare a little bit different, and why in some ways we're coming to that a little bit later, is, I point to two main things. I mean, there's obviously a ton of different things, but one is just the complexity of medical science. I mean, right, healthcare is more complex. It's not just dollars and converting dollars to yen to euros, right? There's actually a lot more complexity in the actual data that needs to be exchanged. And so the standards and the approaches to being able to do that are going to be inherently more complicated. Even if everyone started from the same place, you would still be in the place with the same motivation. You'd still be in the place of saying, oh, healthcare is lagging because the data is more complicated. And that's just the reality of it. The other thing that I think is a key driver of the pace and the trajectory, sort of the pace and the slope of our ability to get the kind of scalability and interoperability that we want is the extreme fragmentation of the healthcare system, particularly in the U.S., where if you think about other industries, and again, just thinking about financial services and banking and airlines and almost every other sector of the economy, you've got more consolidation either on the supply side or the demand side, or sometimes both. In healthcare, you actually have extreme fragmentation on the supply side and the demand side. And that makes it really hard for the industry to get together and agree on a certain set of things and kind of move together, or to have a smaller group of players kind of drive the industry toward a set of solutions that ultimately deliver scalability across an entire industry. And so I think that's where TEFCA comes in and the importance of it. So we spend a lot of time and effort on getting adoption of electronic health records first and foremost. We in 2009, 2010, we were largely a paper-based system, and in a relatively short period of time, and I always sort of sympathize with my predecessor David Brailer, who founded the Office of the National Coordinator in 2004, and he was trying to build telephone networks when no one had telephones. Essentially, it was like all sorts of great ideas, and those were, they were good ideas. I mean, and many of them are enduring. But the problem was no one had any, digital information. So it's like, well, that's great, but until people have digital information, they're not going to feel the demand. They're not going to feel the need to think about how do I interoperate. So the first step was just laying that foundation. Spent a lot of time and effort from the federal government and the private side of just getting that foundation of electronic health records in place. And then networks started to form, somewhat motivated by the federal government with the HIE program, but a lot of it was private sector initiative in the same way that in other industries, right? Once you've got systems, people start to realize, oh, wait a minute, it would be nice if we're going to connect these systems, you need some rules of the road, right? How do we get common rules of the road? Otherwise, everyone's having to figure it out, one in these bilateral kinds of things, and those don't scale, right? That classic 2 to the n problem that everyone's familiar with, hopefully. And then you start to think about, well, what kind of shared services should we have? I mean, we have shared infrastructure services that all of us can contribute to, and that's going to create greater efficiency. And so we started to see more and more networks start to form. And now we're at the point where 21st Century Cures Act comes along and looks at the horizon and says, well, great, now you've got literally hundreds of networks, some of them state local HIEs, some nationwide networks. But now what we need is that network to network interoperability. How do you make that happen? And that's what 21st Century Cures Act did. It's basically said, all right, a bunch of work has happened. There are these networks, but now we need to seal the deal on saying, connect up these networks so that we have that network to network interoperability that's enjoyed by many, many other sectors. And you think about the way ATM networks, for example, connect, and cell phone networks connect. That didn't happen overnight, and didn't happen from the beginning. It happened through industry maturation, a set of conventions, a set of industry shakeouts in some ways, and then public-private collaboration and cooperation to be able to get common agreement on rules of the road, technical standards, collaboration to be able to help to drive that. That's where we are in the industry. Again, it's a very familiar story in almost every sector, and it's now our time in healthcare.
It's funny that you say that, Tripathi. I think I largely feel many of the things that you said, we feel it more acutely, I think, in the markets that we serve. So we talk about both the complexity and the fragmentation of healthcare, because I always ask people when I'm talking to a new partner or potential partner, the conversation typically leads to what the definition of healthcare is, and it's a hospital or a physician. That's the definition of healthcare, right? And of course, we had to start there because that's where largely a lot of the clinical information at least starts from to create the rest of the, kind of the work out into the rest of healthcare. But healthcare by its definition is so wide. And every healthcare business, if you look at it as a business, is a business in itself, and it has its own set of medical data, its own set of concerns, its own set of criteria, and trying to integrate those across the healthcare ecosystem. So starting with the health system, starting with the referring provider, but moving into post-acute, moving into behavioral, moving into social, you start to get real expansive, and they all have their own concerns, and they all have a data set that is somewhat unique to them. Of course, there's overlap on that data set, but as you look to integrate that and move data at scale, that is a huge, complex problem to solve. And that's what's so exciting to me about where we're at today. We're not trying to cut our teeth on net new standards, right? A lot of the standards that we've incorporated have been understood, they're tried, they're true, they're working. Now let's create a trust framework and a group of participants that are very, very interested in seeing it move along based on what we know and what we've learned. And so that's when people ask me, what am I most excited about with TEFCA and QHIN, is that we're not doing something new here, folks. The framework itself is great. The participants are great. So that's new, but we're pushing in and we're finally past the learnings that it took to get here. And we can get into the real work. We can get into the workflows. We can get into adoption and not have to cut our teeth again on what we've learned through some of these previous networks. So that's the most exciting to me. So all of your words very much resonated, especially in the markets we serve. I think it's critically important to understand that we're here, and the federal government backing behind it puts the wind in the sails, and we're pushing forward.
Yeah, and just one small thing I'd like to emphasize, Theresa, of what you just said, is that TEFCA is very much about building on what's already in place today, and to say there's been a tremendous amount of hard work on the private side as well as on the public side, and let's have TEFCA be the thing that's built on top of that to try to connect up and make that even better in the ways that that public and private collaboration and convening can get us to. So it's not about replacing anything. It's not about trying to sort of take anything over. It's about saying, how do we get it all to the next level?
Yeah, totally, Dr. Schoch. And I believe Dr. Schoch is communicating with us.
Yes, I am communicating with you. I was just going to say, Mickey, was that an intentional approach? Is that something that is that you guys sat down in a room and said, hey, we've got all these things. Are we going to recreate the wheel, or are we going to build on what? Was that an intentional decision? Because I think it was a smart decision if it was.
Yeah, I mean, I think that, core pieces of it actually go to the 21st Century Cures Act. I mean, if you look at the 21st Century Cures Act and the provisions related to TEFCA, it specifically says, network of networks. So it's specific, and there's actually a line in there that says something like, in a way that does not disrupt existing networks. So it was very much, in the minds of, congressional leaders, and obviously they got technical assistance from ONC as a part of that. They certainly got a ton of private sector input as well, and I think they, very wisely, sort of framed it in a way that said, continue building, don't, pretend that you're starting from ground zero, and help to motivate what the public and private sector can now do together, because the private sector can't do it alone in healthcare. I mean, I think that's one of the deputy secretary in her remarks when we were going live with TEFCA. One of the things that she said and pointed out was the private sector has done a tremendous amount that they deserve a lot of credit for. But the private sector can't do it alone in healthcare because the federal government and state governments are so deeply involved in every aspect of healthcare that at some point you hit the wall and you say, okay, we got to have the public and private now working together if we're going to get to the next level.
Yeah, I love that. It's a very thoughtful approach. I think a couple of things that resonated with me when you were talking about it. It was interesting to hear you talk about the complexities of healthcare that are different than other industries from a technology perspective. I think there are other things too in the business model that's different, right? The people who purchase healthcare are far removed from let me say it this way, the people who consume healthcare and the people who provide healthcare are far removed from the cost of healthcare because they're generally not the purchasers of healthcare, right? It is purchased through a third party, either through largely our employer or federal government in the case of Medicare and Medicaid, and in some cases subsidized through the ACA for certain plans. Yes, we consumers have a role to play, but we're only paying a fraction of what gets paid for healthcare services in the country. And that's something that has retarded healthcare innovation for years from a consumer perspective, from a clinical perspective as well. The other thing I would say that you touched on that I think is interesting is, to me, I think healthcare understanding the impact of the technical conversation around interoperability. I think that since I've come to a tech company, I hear the conversation all the time on a tech side, and it's important conversation, and people need to have the same language to talk to one another. But I think it's up here, and there are people who benefit from interoperability. They're down here and just thinking, hey, I need to do my referrals better. I need less administrative burden. I need this information at a time where I can make clinical decisions, those kind of things. And so I think there's been a disconnect between how we talk about interoperability up here versus people who need the impact of interoperability down here. I'm just going to add those because they were stimulated by what you were saying, but really appreciate that perspective. Teresa, I know we've got 1,000 questions for Mickey.
Right.
we could pepper them all day.
Peter, just one of the things you just said, and just wanted to harken back to something that Teresa said, which I think is spot on. And she was talking about the Vive conference,
Yep.
But in general, the day that we aren't thinking about interoperability, especially clinical users, is the day that we have fully succeeded.
Yep. Yep.
They're just doing their jobs, and the information is available, and they're not thinking about TEFCA or HL7 or FIRE or any of that.
We're talking about the clinical impact.
Every day they're thinking about that is a reminder that we're still not there.
Yep.
Exactly. And I look at it and say, man, if I could just, again, one conference where it's not the key topic. Now, it's great for the business, right? It's great for discussion, but where it's not I know that we've done our job, and I know that we've at least accomplished the first set of milestones in a long road that we have in front of us. And I think that leads kind of to a next question I have, Mickey, for you, is what do you see? We've hit this kind of these first set of milestones with the application and the designation of QHINs. Tell us some of the next milestones that you think are big and important to the success of TEFCA and QHIN.
Yeah. So I know it's always challenging and hard to get kind of collective action across a very complex and diverse industry. So I think that's been a part of what we think is valuable here, is that the direction from the 21st Century Cures Act and the federal government playing a large role in trying to help to convene, sort of the private and the public sectors to help to drive this. I think hopefully, sort of clarifies market confusion about where all of this might be headed. First off, so people, because I think that that one challenge that I think that we've seen in the market, and there's ONC has a ton of data on this as well, is that one of the things that paralyzes organizations from joining networks is too many networks. Is saying, well, I have 4 options now, and which one should I join? I can't figure it out, so I'm just not even going to do anything. I'll just, keep doing what I'm doing and continue. But hopefully, one of the things we're able to do is say, what? At the end of the day, whichever network you're on, TEFCA is the thing that is the overarching thing. So everyone can point to that now, and hopefully that that helps. So that's a little bit of sort of consciousness, mind share, getting that to the point that. That a physician may not, know what care quality is, or they may not know exactly what Kno2fy is, and they may not know something else. But if they have in their minds that there is this TEFCA thing, that I just want to know that whoever it is I'm connecting with is connected to that thing, and then I'll be okay. Right? I think that'll, that's one of the things that we want to be able to accomplish overall to the benefit of all of us, because that allows you to have the running room as a business. It allows others to have running room. But in terms of, very more concrete things, the value, I think, is demonstrating what is that incremental value that TEFCA offers above what the market does today. Because Kno2fy's got a great network, right? You're already, you wouldn't be a designated QHIN if you didn't already have a track record, of a network. But, but certainly your customers, as well as the customers of, Epic and Commonwealth and eHealth Exchange, are going to be asking the question, what additional value does TEFCA give me that I should go through the pains of, signing this additional contract and, going through all of that? Because I already have some interoperability. And what are those incremental, incremental things? I mean, one is, I think, as I was saying, the assuredness that you're going to get a higher and higher confidence that if you connect to, the TEFCA-based exchange, you'll be connected to almost everything that you care about. The second is being able to fill in some of the gaps that we haven't been able to fill in today. One part is that network-to-network interoperability, but other parts are connection to public health. That we haven't been able to accomplish using the ways that are up till now with sort of the efforts that we have, because that really requires much more sort of public participation. You think about the complexities of public health regulations and different jurisdictions and all of that. And we've heard over and over again as a part of, our reach out as we were developing, sort of the TEFCA model and thinking about how we should shape it. And we heard over and over again from providers, surprisingly, saying that the complexities that we have of connecting to public health are a huge source of burden on us. And so if there's anything that can be done to help to rationalize that, that's a win from their perspective. So I think that's, something that we're very focused on and doing a lot of work on. Another big gap is payer participation and payer-provider interoperability. Again, it's been a big gap in the industry and one that we want to help to solve so that we can get over the competitive jockeying that's prevented that from right now, and that actually right now is a hidden tax on all of us because you have payer organizations, for example, using all sorts of inefficient ways to get information that they're entitled to and that they're going to get. But they're doing it in inefficient ways rather than saying, let's just be clear and explicit and make it efficient and transparent and allow providers to be able to get the benefit of claims data, for example, on their patients so that they can have much better ability to understand where their patients have gone and provide more comprehensive care. Individual access is another hugely important one that has been very hard for the private sector to tackle on its own, again, because it's got all sorts of complexities from a regulatory perspective and others. And then finally is LTPAC, behavioral health. All of those customers I know Kno2 has particular expertise in. They've been left out of the health IT wave and want to be able to do everything we can to say, how do we put into place and get organizations like Kno2 and others who have expertise and experience in that part of the healthcare delivery chain to develop solutions that allow them to join in the interoperability framework that up until now has largely excluded them.
It's playing off some of the kind of the things that you said there, the initial kind of just consciousness of the digital health vendors, but also at the provider level, where the default behavior, even still today, is if I need to share information with a trading partner of mine, my default behavior is to go to a point-to-point interface, and a point-to-point HL7 interface, right, to make it even harder on ourselves. When we see that default behavior invert, where I assume, can I get it through the national network? Can I get what I need through the national network? And that becomes a secondary thought process. Well, maybe I can't, and I need to go to a point-to-point consideration. That is part of what we were talking about at HIMSS and Vive and all these other shows, is seeing that invert will be a major win, especially in the markets we serve. But that is the default behavior we see in healthcare, is do I need to establish either an API connection, point-to-point, or an HL7V2 connection? When that is a secondary thought process, that'll be a huge win. And then one of the things that I think is important in the milestones is what TEFCA and what the ONC continues to drive in all those major milestones that you outlined, but also the responsibility of the QHINs, what their major milestones should be in coordination with that, should really be about pushing into the edge, because at the end of the day, the edge will determine the success of TEFCA and QHIN, not the QHINs. I mean, they are an absolute component to it, but how these edge technologies adopt and absorb workflows to get the provider adoption, to get adoption at all the way down to the furthest constituent on the networks. That to me is a responsibility that the QHINs now have to start to work together and identify key and critical workflows for that adoption, and putting best practices in place and seeing it work through to ensure that we get the adoption at the edge. Because if I was going to point to anything in history that maybe we've not done a great job at, is really seeing it all the way through to its end to get that kind of mass adoption at scale, both for the query and the push side. And I always emphasize that to the groups that are integrating to us. Keep in mind, guys, we've got a query network and we have a push network, and we're going to be focused to both those types of workflows as we push forward. And I think that sits on the QHINs to make sure that they're working together and provide a unified voice out to the market on how those workflows need to work.
Yep. Totally.
Go ahead, Mickey. I didn't mean to cut you off.
No, I was just thinking, like, going back to the point of, how does interoperability happen in a way that you don't think about it? Just think about our day-to-day lives where there is ubiquitous interoperability in certain sectors that we just don't even give a second thought to. Like, you have a Vanguard account or a Fidelity account or whatever it is, and you want to connect your bank, or Venmo or Cash App or, whatever it is, and you want to connect your bank. What do? You go in It says, what is the ABA routing number of the bank?
Yep.
All of us like, no, okay, let's type it in. Some of us know it by heart because we have to do it so many times. And then your account number and all of that stuff. But think about what's going on behind the very fact that there is an ABA routing number means that there is actually a network behind the scenes that recognizes that, oh, that bank has this routing number, and then it all works, right? You put that in and it all works. We don't have that experience yet in healthcare, and that's the kind of just ubiquitous sort of interoperability that we all take for granted, that we want to be able to have. Because otherwise, if your bank didn't have an ABA routing number, and I assume there are probably some that don't, what does Vanguard or Fidelity say? Well, send us a check. I mean, how else is this going to work? Or we'll send you a.
Think about what it takes. That's a perfect example of. So we had the network that put in the ability to exchange those data elements, but to make sure that that worked at the edge in the Vanguard system, in all these different systems, there was a lot of thought and consideration that had to go into that workflow, probably far beyond what we could have even considered in this discussion, to make it actually work. Because that network could have that capability all day long to share that information, but if it didn't manifest itself in the edge, it's dead on arrival. Doesn't matter. And that is key to success for us.
And what also drove that was in the consumer's hands, right? The consumer was making that choice. The consumer saw the immediate impact of that. They had a need to connect those accounts. They could see that need. And I'm not sure it's as clear in the provider world. But a couple of things that you said, Mickey, that I want to come back to and trace in that conversation that stuck out to me. I'm going to go ahead and admit that I might be a data socialist, and that may be a bad thing to admit on the podcast. And what I mean by that is, as a provider, I want every one of my colleagues, and when I use provider here, it's really a ubiquitous term to encompass anybody who's on the front lines delivering care to patients in whatever sector of healthcare. I want them to have all the information that is necessary and all the knowledge necessary at the point of care to make good, rapid clinical decisions in the best interest of their patients, to drive outcomes, safety, all that kind of stuff. And so I to me, that is, and let us compete as a provider. If I'm competing with a hospital down the road or competing with a internist down the road, let us compete on what we do with that information and how we serve our patients in that regard, but not compete for information in that regard. And one of the things you were talking about with the payer provider interoperability and the claims data, certainly in a pop health space, it's incredibly important to understand the patterns of care that sometimes are most clear through claims data and where they've received service. But to me, that is hopefully one of the promises of TEFCA to me, is that with the public-private partnership, there is enormous influence without being over-controlling that the federal government can provide in the sector to help break down some of those barriers, so that we're enabling much more free flow of information and what I would say data socialism in my mind. The second thing I think that struck me as you guys were talking, I agree 100% that the framework is critical. And now that we have the framework, it's almost hey, Mickey, great job. Great, 10 years of work getting it all done. Now what? I know we're all asking you that question, but we're shifting to the burden of adoption now. But I do think that Trace it to your point, and Mickey, to your point, that is the critical component. And I would ask you guys, what do you think has been the barrier to adoption to date? Because I know there are many more people that have the potential to be connected than are actually receiving the impact of being connected in their day-to-day lives, in a hospital, in a home care agency, or in a physician's office. What do you think are the current barriers to adoption that we need to look at and address differently, perhaps, or more fervently moving forward for TEFCA QHIN?
I'd say it's, I'm sorry, Dr. Tripathi, I'm actually going to, I read a result of yours this morning. It's got to be easier than the fax machine. Sorry to be that fundamental, but it has to be easier than the fax. And I'm talking about the provider workflows, obviously, here. It's got to be easier than the fax machine. And to use a corporate buzz phrase that's overused, but I'm going to double click on what Dr. Tripathi said on the post-acute space. So I'll give you a perfect example of this. And I'm living it real time with the active networks with Commonwealth Care Quality. We've got post-acute partners where the health system, based upon the definition of even the clinical content that's shared, we're using LOINC codes, for instance, to identify what types of documents get shared. And post-acute was completely not thought about in that definition. So what some of our major EHRs have implemented have been all the discrete operative report, discharge summaries, all those discrete document types that get shared all the time. And then they get to post-acute, we have one kind of catch-all, and it absolutely provides no value for workflow when it goes back to that referring provider. So it just sits in this kind of junk pile of information. And our post-acute providers that we're representing are saying, Teresa, our referring providers are saying it doesn't work. This, even though we're connecting, we're sharing, it's a joke because it doesn't drive what it needs to on that referring provider side. So, I'm all over those types of things. And they're saying, I don't know if I should adopt because it doesn't really benefit what I needed to. And the fax machine actually does a better job because it gets right to the provider. They know what to do with it and they know how to action on it. So those are the types of things to answer that question. Sorry to probably give it the most blue collar answer you could have is it has to be easier than the fax machine. It has to work better than the fax machine.
As a provider, it resonates with me. I mean, I remember when we were looking at ways to try and enhance clinical documentation and improve efficiency in that process, and we wanted to use dictation and then voice recognition software integrated to the EHR and all that kind of stuff. And what we used to tell people is until it's as easy as us just talking, it's probably not going to be readily adopted by providers, right? Because that's the easiest thing. We want to be able to talk and be able to have those words magically transcribed into a note that makes sense. So I don't think it's blue collar at all. I think it's real, and I think hidden in those comments are the issues around workflow and what the Edge does for workflow, and number two, the change management. When you think about the complexity of healthcare and the fact that workflow changes that we talk about those a lot, but every workflow change requires significant change management and potentially impacts, at least in a short while, the operations of the business in a way that may impact revenue streams for provider offices, home care agencies, hospitals, and so forth. And I think I think we've got to be talking about those things more as we move forward. And then last thing I would say on this, one of the other unique things about healthcare that we didn't talk about earlier, we touched on it, is this intermediary in healthcare called the payer, whether the payer is the federal government, whether the payer is a commercial payer, and the premiums are paid through taxes or through partly through our employer. That intermediary makes for some very difficult conversations around changing business models, clinical models, and so forth in healthcare. I think having the intermediary in technology, the equivalent of the payer, would be the EHR vendor. And this is not a demonization of that because we need that in order to be digital. But interoperability to a degree is dependent upon how each one of those systems of record processes the data, integrates with the workflows for their providers such that they actually receive the impact. And maybe that's not a fair statement or a fair burden to put on them, but I think it's true. And I think that's part of the process to me from an adoption perspective. But I'd love to hear y'all's perspective on that. I really would.
Yeah, I guess, I was going to give actually the same immediate answer as Teresa did. With respect to it's got to be easier than the fax. And people I've been on, like in the last 2 weeks, I've been on a number of calls and interviews where people are like, so when are we going to get rid of the fax? And it's like, well, we're going to get rid of the fax when it's not the easiest thing to do. That's when we're going to get rid of the fax. I've had an experience that many people may be sick of hearing now, where my mother was being transferred from an acute hospital to post-acute rehab hospital. Both of them one was on Epic, one was on Cerner. Very well-functioning systems. I know they're connected on the back end. Yet, when we were when my mom was being discharged, they printed off her record and handed it to me. Why? They're not stupid. They're not evil. They actually didn't know that there was an electronic connection on the back end. There was one issue. And a part of not knowing was that the easiest thing and the thing that was just embedded in their workflow was printed off and handed to the patient. And then they'll scan it on the other side. And, and then another source of evil is the e-fax. So, someone was telling me, well, like in Epic, for example, there's an e-fax button. So at that point, it's just as easy to e-fax fax as it is, to a physician. It's like, well, I just pushed a different button How does that solve, because it's not as if, most faxes are going with people actually manually feeding into a fax machine, right? It's actually electronic fax.
The equivalency is how many clicks, right? If
Right,
if it's all one
we even have
click.
to raise that to a higher level to say, wait a minute, if we're all e-faxing, there's a tremendous amount of value that we're losing here. Some of the things that Therasa was talking about, we're not going to be able to take that information from a fax and actually integrate it into a workflow and get us the kind of automation that every other industry has been able to benefit from, that we still struggle with in healthcare. So I think that's a big part of it. I think it is a shared responsibility. I mean, to your point, Peter, of, well, the vendors do play a big role. I, sort of going back to my, I'm a hopeless economist. You sort of think about, in a very fragmented healthcare system, you've got patients. If you think about the entire value chain, you've got patients, you've got providers, you've got payers, and then you have EHR vendors, and then you have the government, obviously, state and federal government. You think about the fragmentation in almost every one of those places, and then you realize, oh, wow, the greatest consolidation in some ways is in the EHR vendor space, right? Where you have like 10 vendors, 12 vendors. If you look at the ONC, website for this data, 10, 15 vendors, account for something like 80, 85% of the providers across the country. And then you think about the collective action problem there. In some ways, you sort of, like an economist who knew nothing about healthcare would kind of come in and say, well, obviously, the group, that part of the value chain that has the easiest ability for a group of players at some point to get together and say, you know what, if we lay down our arms around a certain set of things, we can actually achieve more for the industry. We'll all benefit. It'll be the tide that that lifts all boats, and that'll help us move forward. And where have we seen that? Interoperability networks. The existing ones, Care Equality, Commonwealth, Care Everywhere, right? Those were vendor driven, in part because the vendors were the only ones who could, sort of say, you know what, if 10 of us agree to something, we can actually drive the industry in a way that makes it's hard for providers and payers. So anyway, so I do think there is, sort of that phenomenon for sure. But I also think it is very much a shared responsibility. If you think about, that story that I was just telling with my mother, a part of it, one could argue, is, what, Epic and Cerner in this particular case, I'm not, trying to just pick on them, but in this particular case with these two hospitals, Epic and Cerner did a lot of the hard work of actually building that electronic connection, right? Mm-hmm. That's actually there. They did a tremendous amount of work to make that happen. And I would argue that in this case, it was the provider organization's responsibility to say, we are actually going to implement that all the way down to the bottom of the food chain. So that's where I would lay blame, at least on that part of the problem, to say, why are you as provider organizations not doing that? Why are you allowing this to persist in your organizations?
I 100% agree with that.
What Therasa was pointing to, that, well, but the standards aren't great, so that's why the fax is still better. Well, but that's that's work for us to do, right? That's work for providers to do. The vendors aren't going to solve that on their own. So I think that's that part of that shared responsibility. Just one last thing I want to say, going back to a story of when I first got into health IT. When my first entree really into health IT was in like 2000, 2001. Where I was working in Indianapolis and ultimately founded the Indiana Health Information Exchange in Indiana. And one of the things that we did is we built the platform. IHIE was originally about lab results delivery, electronic lab results delivery across the entire market. And we got all the hospitals to collaborate on this one platform, this shared sort of nonprofit platform, to deliver lab results through a single mechanism, so the providers weren't having to get a fax here, paper here, log into 5 different portals over here, and to basically convince the hospitals that this is not a competitive advantage for you. It's actually commodity. You should just be sharing this like you share your laundry services. But the thing that got it over the hump was we literally went to every hospital, and I think there were like 11 hospitals in Indianapolis at the time, and we got them to agree to send out a single letter to all of the providers in the community saying, all of us as hospitals will no longer send fax or paper lab results as of this date going forward. And if you want your lab results, you have to connect to this nonprofit organization, the Indiana Health Information Exchange, to receive your lab results. And that's what it took, right? Because it was just going to be this long tail of paper and all of this. And finally, they just agreed, you know what? We just have to cut it off, communicate the date, and give them a better solution. And ultimately, I think that's what helped drive, a terrific business model in Indiana.
Yeah, that's fantastic. Trace, I know we're coming close on. We're really using a lot of Mickey's time here, but I would be remiss. It looked like you were going to ask another question. I think we'd be remiss without asking how we see, or how, Mickey, do you see other sister agencies within the federal government helping to drive the adoption of QHIN, or how are they viewing QHIN, and what do you think their role is in driving adoption? And Tracy, we'll come back to your question. I'm sorry to interject there, but I just want to make sure we get that out.
Yeah, absolutely. So for anyone who didn't see the go live event in January, and Kno2fy was obviously designated a little bit after. Not no issues with that. We're very very grateful and thankful that you have done that. But that go live event January 12th, or I think it was 14th actually, when Secretary Becerra spoke. I'm forgetting the dates, but it's on the ONC website. One of the things that he said, I think, and communicated over and over again as part of that, is that TEFCA is vitally important to the federal government. This isn't just an ONC project. That every agency within the Department of Health and Human Services, for sure, is thinking hard, and and we're working with them on thinking hard about how do they leverage TEFCA to help support their mission objectives first and foremost, and to help support their internal operations to make it more efficient for the things that they do. So we're working with the CDC, for example, in a pretty aggressive manner, I would say. I'm not aggressive toward the CDC. The CDC and ONC working aggressively together to drive TEFCA adoption by public health agencies. And we've got a number of public health agencies who have stepped up and said, we'd like to be the lead adopters in that. And I think that'll be hugely important breakthrough for us to be able to demonstrate that here are some jurisdictional public health agencies who are now full participants in TEFCA exchange and getting the benefits of network interoperability, both to rationalize the information that's coming to them, that's already being sent, but in a wide variety of cumbersome point-to-point interfaces, but importantly, being able to provide information back and have more, what we think of as modern interoperability approaches, like the ability to query for information, back from provider organizations in a way that makes it easier for providers and gives providers a sense of, the public health information being valuable to them. So that's one example of, working with the CDC. We're working very closely with CMS, for example, a number of areas. They've already put into their payment rules credit in promoting interoperability and other things for, TEFCA-based exchange. We're working with them on, how do we align the requirements from the CMS interoperability rule, for example, for payer APIs, to be able to say, how can TEFCA support that and support the scalability of that if you have payers who are not going to be required to make available FHIR APIs? And that's why, FHIR is such a critical part of TEFCA, to be able to support, what they're doing there. The other work that they're doing on a nationwide healthcare directory, for example, that some may be familiar with. Well, TEFCA has a directory. It's an endpoint directory of electronic endpoints already. So working closely with them to say, how does that fit in, a more in a federated type of approach to nationwide directory services to better serve, all healthcare participants. And we're increasingly working directly with FDA and NIH, who are very interested in the research use case. As you can imagine, you start to think about, post-market surveillance for effectiveness of systems that have been approved by FDA, whether it's drugs or devices, for example, and NIH and everything they do with clinical trials and, in development, and FDA obviously with clinical trials. Tremendous amount of opportunity there from the research space. So we're rapidly trying to accelerate what we're calling the seventh exchange purpose, for research. So those are just some examples of how we're working directly with our agency partners. Oh, and VA. Critically important. I think that, for anyone who heard Sharif Al-Nahal, and who's the head of the VHA, speak at the TEFCA event, I think one of the things that he said is that for the VA, this isn't a question of if, it's a question of when. Is the VA going to, join TEFCA? They've got a number of different options because of different vendors they have, but, they see it as critically important to be able to get the kind of interoperability they need to serve patients, veterans, and in particular, given that a disproportionate number of vendors live in rural areas, which is, a big gap in our interoperability networks. And so they see it as critically important to be able to get that kind of connectivity that has been very hard for them to accomplish in the absence of TEFCA.
Mickey, that's fantastic. I love to see the federal government eat its own cooking, so to speak, as we as we said when I was growing up. But I think that's very powerful. And when you think of all the interconnections between those agencies, the people they serve, and the information they have, with healthcare and different healthcare, private healthcare entities, it's incredibly, incredibly important to understand their perspective and how they're coming into the fold for TEFCA QHIN and supporting it. Teresa, it looked like you had a question that you wanted to ask before we go and finish this segment. Did you have an additional question?
Yeah, probably not. We kind of passed that topic. No problem. I'll emphasize what Dr. Tripathi said there with especially with CMS as we look at things.
Calling me Mickey, Teresa. All these years,
And when does passing a topic have anything to do with whether or not you're going to bring it up again? I don't understand that at all.
I've never felt that behavior before. I always feel that. Just out of interest of time and respect for Mickey's time schedule, I'll just emphasize what he said on CMS, especially for the audiences we serve. And I think I'm their loudest voice, their advocate in this industry. But the prior auth APIs being available through the huge amount of administrative burden that presents to the audiences that we serve that are very dependent upon prior authorizations for anything from home services, therapy, everything. That I'm super excited about the federal government getting behind that and our ability to take the workflow again and make it. There's no way it could. If we don't make it easier than what they do today, then I have completely failed at my job because it only one move to the right and it's easier than what they do today. So I'm super excited about CMS participating in that, and I think it's a huge show of display just to say, hey, we're ready to do this. We need the other side to come to the table. And solve this workflow challenge, not only for the providers, but the patients are impacted every day, and not in a good way today. And we need to see that solved.
It's interesting as you guys talk. I'm going to close this segment with this thought. We always talk about healthcare being a team sport from a provider perspective. Healthcare is a team sport in a lot of ways, and I think interoperability, because of its nature in connecting information, connecting sources of information, really begins to speak to healthcare being a team sport. Payer, Mickey, everybody up and down the value chain has a role here to improve the process for each other and ultimately the people we serve. So really excited about that. We're going to take a quick break. We'll come back, wrap things up with some final thoughts from Teresa and Dr. Tripathi. Back in just a minute.
Discover the untold stories of the talented mind shaping Kno2fy. In this employee spotlight, delve into the journey and passion that fuels our team.
Can I have you state your name, title, and what you do for Kno2fy?
Yeah, Matthew Harp. I'm the manager of client activation, and pretty much exactly what the title shows up. Head up all onboarding as well as act as the bridge for support to the engineering team.
What would you say your why is for working at Kno2fy or in healthcare technology in general?
I think the end goal, really. I think all of us have experienced some of the pains that the medical system has, especially with data and communication flowing back and forth. Definitely firsthand with some family members. So the reason that I work here is to try to make others' lives easier when they are going through something in the medical system.
What would you sing at karaoke night?
I believe in a thing called love. I think that's it, by Journey, or The Darkness.
All right.
Yeah, that's a classic.
like
and you
it.
do have to use a lot of voice inflection, so I'll definitely embarrass myself.
Can you name one thing you love and one thing you hate?
One thing I love is golf, and one thing that I hate is playing poorly while golfing.
If you could, would you be friends with yourself? Why or why not?
If I could, I would believe, yes, I would be friends with myself because I try to never give somebody a reason not to like me.
Do you have an outfit, trend, hairstyle, something like that you wore growing up that you would be mortified to see yourself in today?
Mortified is tough, but I was known for wearing tall white socks. I never wore ankle socks. With that being said, I still do wear them today, and I'm still kind of ashamed that I got that from my dad. So,
what is the favorite room in your house and why?
Well, so we just got this house few months ago, and as you can see, this room is still pretty bare. This room is going to be my favorites because we're going to turn it into a game room / like retro bar back in that area. That's the project to come, though. So I'm going to go with the bathroom because it has the shower, and our shower is awesome. I love a nice long hot shower.
All right. Last question. If you could be a superhero, what would be your ideal superpower?
Oh my gosh. I have a funny joke that I used to get out of this conversation, but I'm not going to use that. Flying. I mean, inherently, the ability to fly solves so many problems for any given person.
Naturally.
So we'll keep it simple and stick with flying.
I like that. That's a good answer. I would do it too. All right. Well, thank you for chatting with me today. It was nice talking.
Of course. Thank you.
Stay connected for more behind-the-scenes narratives as we continue to unveil the stories within our remarkable team. Connect, listen, transform. This is Kno2fy with your hosts, Dr. Peter Schoch and Therasa Bell.
Welcome back, everybody. As we wrap up this episode, we've had an incredibly robust and far-reaching conversation, and I hope that you found it as insightful as I have. And really, again, Mickey, I really have enjoyed the opportunity to have you here and having just an open conversation about these things. Really, I think helpful. And so, Therasa, as we normally do, I want to go to you first, and any final thoughts, anything that you heard that you didn't say you want to say, anything you want to leave the audience with?
Other than, I'd just say, thank you for bringing the torch this far, Dr. Tripathi. We'll pick it up, and I guess we'll light our torch because you're continuing to carry it. We've lit our torch as QHINs and take it very very seriously, and very. It's a big push effort that we have going into the market over the next 2 years, and we're going to see this through to its success. So thank you for all the work that you've done, and we're here to bear that weight with you and carry it forward.
Well, thank you, Ms. Bell. Really appreciate I just want to, really appreciate being here today. So thank you for the opportunity, and also just want to, thank Kno2 for everything you're doing. As I said, we didn't get authority or budget, to tell anyone or to, pay anyone to participate in TEFCA. And I think it's, organizations like Kno2 who have, stepped forward to make the investments and to contribute to this critical nationwide infrastructure that are going to make it happen. So really appreciate everything you're doing, and look forward to collaborating together in the future.
Guys, I think that's a mic drop event for me. I don't know what I can add to that. I think, again, I'm just really, really appreciative, and I think the future is very bright. I would agree with Therasa that the table's been set. Now we need to feast on what's there to actually accomplish the goals that we set out to accomplish, to realize the impact of interoperability across healthcare. I really do think that it is foundational to solving all of the big problems in healthcare, is getting information flowing at the point of care that allows us to improve our operations as healthcare entities, improve the provider experience, and address the concerns that are causing people to leave healthcare who provide healthcare, and address significant patient experience outcomes, safety, coordination of care, et cetera. So I think there's so much to be gained. And I think the U.S. healthcare system as a whole benefits from interoperability from a cost perspective. All the population health and value-based care efforts that we're moving to are requiring the need for interoperability at scale. So really look forward to what TEFCA QHIN brings forward and being part of the fight. I think it's a really noble cause, and having been a provider for so many years, it's just what the doctor ordered, so to speak. So we'll see you all at Vive, both Dr. Tripathi and ourselves. Now, and I say Dr. Tripathi, he gave me trouble at the break for calling him Dr. Tripathi. Mickey is going to be at Vive on many stages. Please get an opportunity to connect with him. If you get the opportunity to stop by our booth or hear Therasa or I speak, we'd love to see you there as well. So thanks again for listening. Until next time.
Thanks for joining us today. That's a wrap for this episode. Please subscribe or follow on your favorite podcast platform to make sure you don't miss an episode. Get Kno2 connected today and set yourself and your organization free to unlock your potential. For more information on the value of being Kno2 connected, visit us at www.kno2.com. Follow us on LinkedIn or Twitter. Connect, listen, transform.